Healthcare is becoming less human, and convenience is replacing care. How can we restore human dignity to the heart of medicine? Hi, this is Nicole Scheidel and our weekly look at life issues in healthcare. And today I'm joined by Dr. Natasha Fernandes. Welcome, Natasha.
Hi, Nicole. Thank you for having me.
I'm so glad you're here. So you're a psychiatrist who works with adults with developmental disabilities. How did you come to specialize in this area?
It's so interesting because I don't think that I found it, but it found me, at the risk of sounding cliche. In my medical school years, I just happened in a lot of my rotations to come across this population. And I just realized how much I loved interacting with them. I really feel like they are angels on earth, and it's such a privilege working with them. That's how I view them, and I think everyone really should be, is my bias. And so it just was such a natural fit. My uncle on my dad's side had Down syndrome, which is not something that I really particularly had thought about a lot, but I now, in retrospect, in my field, feel that it's just interesting how I have that history in my family, and I feel very touched by it.
So what did you study in particular to get you to the spot where you are today?
So my school training, you mean, or just
Yes, yeah, your school training.
Oh, how much time do we have? So after my undergrad, I did a 2-year master's in clinical epidemiology. And that's because I didn't get into medical school. And I also, by the way, do another talk on failure and dealing with that. So sidebar, and so then after my master's, then I applied, I got into Ottawa Medical School, and I did 4 years there. After that, I did 5 years in psychiatry to specialize in Toronto. And then I graduated last year. And so this has been almost my first full year of independent practice.
Okay, and do you practice at the hospital or at a clinic? How do you work with adults with developmental disabilities?
Yes, so I only work in a hospital. So right now I'm at the Center for Addiction and Mental Health, which is the mental health hospital in downtown Toronto. I work in a very specialized clinic. I'm super lucky. I work with a lot of allied healthcare professionals like social workers and behavioral therapists. And so it's an outpatient clinic, but I also see patients in the emergency department or in inpatient units if needed.
Okay, and so we've just come through the COVID pandemic. What were, from your perspective, the unique challenges faced by persons with disabilities due to the pandemic?
Isolation, Nicole. And isn't that the case for all of us? I think that it's so sad. I think it really showed how isolated we all are, and in particular that population. It just breaks my heart. Like the resources that were just taken away, right? Just abruptly, almost overnight, from some of these folks. They didn't really understand why. They didn't understand what was going on, and there was just like no thought around how that would affect them. And so their support workers got taken away, their day programming, any kind of social interaction was removed. And so I think that sense of isolation has been huge for them.
And so do you think it was like you said, we were all face isolation, and a lot of the problems, I guess, would be amplified because of their disabilities and their inability to maybe communicate some of the things they were feeling that we probably were all going through, but for them it was a more acute situation.
Yeah, and I think, you and I might be able to reach out to others who aren't paid to be there. But for some of these folks, some of their closest people are paid to be there. They're case managers or personal support workers. And so it becomes harder, right, when those supports get taken away because they don't really have other people to reach out to. And so, yeah, I have some patients, I think they see me as a friend, which is completely fine. But so these are the kinds of built-in things that get removed.
So would you say then that individuals with the population that you serve, they interact with their healthcare team differently than other people might?
I think so. I would say that. I think that they almost create a family and they form a community with those that they work with. by and large, like they're so affable that everyone who works with them automatically wants to be their friend, right? Or wants to be one of their loved ones. And so I think it creates a different kind of atmosphere.
Okay, I wanted to, we talked a little bit about this before we started, but I want to bring up this quote and read it, and then I'm going to ask you to respond to it. So this was from JD Flynn. He has adopted 2 children with Down syndrome, and he wrote this. He said, "I have realized they are not unique because they suffer. They are unique because they do not hide suffering well. It does not occur to them that suffering might be secret or a source of shame. I mask anxiety with a veneer of confident affability. I know how to make it seem I am doing better than I am. I have picked up the idea that I should project strength, independence, and poise. My children have no such pretenses. They are exposed and vulnerable, and they challenge me to live that way. It rarely makes me comfortable, but I have found it often leads to real intimacy and authentic friendship." So tell me what your response to that is.
Okay, so I very much think that 100% is his view, right, and his experience with his loved one. Um, I do have a little bit of a different experience, and actually, I do teaching for the residents, the psychiatry residents, and I teach them that when someone with a developmental disability comes to the emergency department, you actually have to be careful because they might be masking their deficits. And so, I think we should probably define what a developmental disability is. And so that's someone with an intellectual disability or autism with like significant impairments in their social functioning. Um, and so they can range, right? So it can be really quite mild to more severe, profound impairments. And when someone particularly who has a mild intellectual disability, and this actually tends to be people with a Down syndrome, they have insight and they're aware that they might be a little bit different than the neurotypical population. And there is this desire to try to fit in and to make it seem like everything is okay or that they're not struggling or they're not doing that badly. And so it's important to ask the right questions, ask caregivers and loved ones to make sure that is truly the case. I also recently saw someone who it was very interesting to me and almost heartwarming.
Yeah,
Oh,
no, keep going. It's good. Don't worry.
I lost Nicole.
Yeah.
Okay. It was very heartwarming because I was asking him if he was hearing voices, like auditory hallucinations, and he told me in front of his mom that he was, and she was shocked, and she said, "What? You didn't tell me this, and I've asked you, and you said no." And he so sweetly told her, I don't want you to worry, so I don't tell you that. And so I think that they're such genuine individuals, and they're so caring and thoughtful. So while certainly a lot might be unaware to hide what's going on, I think we shouldn't underestimate what they are aware of.
Sorry. I just thought people might like to listen to you more carefully than having me there. So I didn't mean to startle you.
Oh, it's me.
Yeah, no, that's fine. So just going back to thinking about that interactions in the hospitals, in what respects are there more supports or less supports than people might expect for meeting the needs of persons with disabilities? Like obviously in the emergency room, people are trained to deal with individuals who have those deficits. Are there other ways that the healthcare system is sensitive to the needs of individuals with intellectual disabilities?
Yes, so I have to say I'm really proud, at least at CAMH, and I'm sure at other emergency departments, there's a real attempt to try to address their needs. In particular, emergency departments can be very noisy, right? Very busy, very chaotic, and we know that for a lot of these folks, they can be very sensitive to much stimuli around them. And so certainly at CAMH, we try to see them first, to see them quickly, maybe give them a separate room. So there's a lot of attempt to support their needs. I think, unfortunately, I think there's probably more holes and gaps in the system than there are supports. And I tell everyone, if I'm just starting my career, but by the end of it, if my only contribution is to increase those supports by like a fraction, I will be very satisfied, because right now it's so disheartening to see they're the most, in my opinion, they're the most vulnerable people in our world, and they're not being heard. The supports are so lacking. And this is a developed country. You would think that we would have these kinds of things in place. So I'll just give you some tangible examples.
For sure. Yeah.
So if you have a developmental disability, there are at times can be what we describe as like maladaptive behaviors, right? So learning that if you hit mom, that's when you get your treat is not a good behavior, but it can be developed over time and reinforced because mom ends up giving the treat, right? And so that can end up creating a very unsafe environment in the home. And of course, there's no intention to do that, but unfortunately, it's been reinforced. And so, in those situations, usually, we try our best to help support in the home and increase supports, but sometimes they just need to be removed from the home. It's the home environment that is not very good for them. And they flourish and do so much better if they're taken out, put in a group home. But what's devastating is that the wait times for group homes can be anywhere from 10 to 15 years. And so you
Sorry,
can
do you want to say that again? 10 to 15 years?
yes. And so this is the challenge that we're left with, is that you have people who are in unsafe environments. There's literally nowhere to go. And that was there was a study done, a report by the Ontario Ombudsman's Office back in 2014 or 16, sorry. But anyways, and the title of the report was Nowhere to Turn. And I think that was, it captured it so beautifully, how there's nowhere for these poor guys to go because there's just no funding. And historically, what happened was, like way back in the 1800s, we had no housing for them back then either, and they would end up in the jail or kind of forensic system. We've improved slightly, right? So eventually transitioned to them being placed into asylums and institutionalized, which had its own evils and they weren't treated well there. But then the deinstitutionalization of these places and then just completely leaving them in the community without the promised supports that were supposed to be put into place has really left them deserted. And the difficulty is that it's the Ministry of Social Services that's supposed to be responsible for these outpatient supports, and they're just underfunded. They don't have the money, and this is the struggle. So and that's what I'm referring to when I say if I can just increase those supports a little bit in my career, I'll be very, very pleased with myself, because that's what they need, is literally a place to stay is what is our goal at this point.
So we've kind of seen that in the news lately, with a lot of the euthanasia happening around lack of social support. So women in particular with unsafe housing or housing that doesn't meet their needs, and they're opting for MAID instead of getting better housing. Do you think that that is going to bleed over into this population as well?
Yes, I think so. Hopefully, we never know with this government, but hopefully, euthanasia will never be extended to someone who is not capable of making that decision for themselves. So, when we're talking about someone with an intellectual disability, my true hope is that they would be protected. However, people with autism without an intellectual disability, in my opinion, and that also is a population I work with, are so vulnerable to euthanasia. And they're not protected because they typically can have the capability to consent. And so for them, there can be high rates of suicidality in that population, actually, and it's more so than your typical population. And one of the theories for that is they feel that they are isolated. They don't fit into the society, into the world, and therefore they're isolated. They're a burden on others, and they don't belong. And again, it's so heartbreaking, right? Like the fact that you're suicidal because you feel you don't belong in this world, and then to offer them euthanasia, right, instead of maybe changing society. Maybe we could truly become tolerant in the actual sense and be welcoming to someone with autism. that's not really the world we live in anymore. And so I think that's why euthanasia is really, really scary for me, particularly for that population.
So one thing I was thinking about when you were talking about a lot of the support they need is on the social side. So really, their health care has this huge social component to it. Just working with this population, what kind of insights do you have in terms of what it means to care for the whole person when we're talking about healthcare?
Yes. I think it's really made me realize, you know, that saying how we're not human doers, we're human beings. And this population has really highlighted that for me. I think if you look at someone's value based on what they do and what they can contribute to this world, you're missing out on so much, because my patients like bring so much joy, not only just to my life, but to their loved ones, to people around them. And if you're only going to measure them based on what they'll be able to provide tangibly, I think you're be missing out on so much. And so it's I think that's like the holistic person is more so more than just what you do in this world. It's who you are.
So just thank you so much for coming on to talk with me today about this issue. If you had to speak to someone who is considering medical school and maybe working with this population in the place that you work, what would you tell them?
Uh, do it. um, I have to say it's such a joy for me to go to work in the morning. It's challenging. I won't sugarcoat it. I won't put the rose-colored glasses on. It's such a challenge because of the lack of social supports, and so people are coming to me, and it's hard, right? Because I can't give them a place to stay. I think that's where the compassion comes in, right? And you suffer along with them when you can't make the fixes. But I just there's so much learning to be done. I feel constantly humbled, and it just the things that my patients share and teach me is such a huge kind of life lessons. And and so yeah, I think if you're looking for a job where you feel that you're working with a population that is truly, truly vulnerable, actually marginalized, you want to give voice to their concerns. This is a group I think that would be very satisfying.
Well, thank you so much for joining me tonight and telling us about what you do. And I think that the people you serve are so lucky to have you.
Thank you, Nicole. I appreciate it.